Welcome to Taming the Flames, a presentation of the International Atherosclerosis Society. I'm Peter Libby from Boston's Mass General Brigham Hospital and the Harvard Medical School, and our theme is Taming the Flames. And my particular brief today is to talk about assessment and managing of atherosclerosis risk, but what has research taught us? It's my pleasure to work with my colleague and friend, Dr. Paul Ridker, and I hope I will be able to set him up with our basic science discussion to follow. These are my competing interests. Well, there's been a lot of evolution in our thinking about atherosclerosis in the last years. Actually, Virchow in the end of the 19th century very clearly visualized inflammation as part of atherosclerosis. But then in the ascendancy of biochemistry, it became clear that cholesterol was important in atherosclerosis. Then there was a phase of focus on cell biology with proliferation of smooth muscle cells as the key. And then we came back with modern tools to Virchow's original idea from the mid-19th century about inflammation. And today we believe that atherosclerosis actually is a combination of all of these various mechanisms. I call your attention to Dr. Russell Ross's important work, where he called attention to the proliferation of smooth muscle cells. And in his initial formulations of the response to injury hypothesis, he did not include lipids and he didn't include inflammation. But now we do believe that inflammation is intrinsic in all phases of atherosclerosis, from the very beginning through the long, clinically silent or stable phase of this disease, up to and including the thrombotic complications that bring the patients to our attention as clinicians most dramatically. It's very important to keep in mind that there is no competition between traditional risk factors, such as low-density lipoprotein, and inflammation. Rather, inflammation provides a series of biological mechanisms that link the traditional risk factors to altered behavior of the artery wall that give rise to the disease and its complications. So it's very important to keep that in mind. It is a false dichotomy that inflammation is contrary to traditional risk factors. Well, I've spent many years trying to understand the cellular and molecular mechanisms by which inflammation can cause atherosclerotic events and grow the plaque. This is a figure from a review that I wrote that encapsulates decades of work in my laboratory. When we have inflammation in the intima, as portrayed by these yellow macrophage foam cells and the less numerous blue lymphocytes, there is a conversation that goes on between these cells that jeopardizes the strength of the plaque's protective fibrous cap, which owes its tensile strength to interstitial collagen, this tightly wound triple helical molecule, which is very stable normally. We found that activated T cells can secrete a pro-inflammatory mediator known as interferon gamma that can halt the ability of the smooth muscle cells to make new collagen required to repair and maintain that all-important protective fibrous cap. That's all that stands between many of our patients and an acute thrombotic event. We also worked out the conversations between the T cell and the macrophage, which turn on the potent procoagulant, which makes it so dangerous for blood with its coagulation factors to gain access to the lipid core by turning on tissue factor procoagulant. We also found that inflammatory stimuli, including the one depicted here, can rev up the production of a specialized set of enzymes that can make the initial proteolytic cleavage in this ordinarily very stable interstitial collagen molecule, setting up the stage for weakening of the plaque's fibrous cap. So when we have inflammation in the intima, we put the plaque in double jeopardy: decreased synthesis of collagen and increased breakdown. That sets the stage for the acute coronary syndromes. More recently, we turned our attention to another mechanism of acute coronary syndromes, superficial erosion, which also involves calcification and also has categories of inflammation, but different than what we see in plaque rupture. It is the unwelcome visitors to the artery wall, the inflammatory cells, which cause much of the mischief during the pathogenesis of atherosclerosis and its thrombotic complications. You see some of the different cell types which have been well characterized in atheroma and some of the mediators that they release, which promote the disease. But things have gotten much more complicated in the single cell era. As you can see, we now have many, many different subtypes of inflammatory cells in the atherosclerotic plaque, which is a subject that deserves its own symposium. So what is it that causes these leukocytes to accumulate in the atheroma? Is it recruitment from blood, local proliferation? Is it extramedullary hematopoiesis? Or is there a relationship between hematopoiesis in the bone marrow and atherosclerosis? Indeed, it's all of the above. And what triggers the accumulation of leukocytes? Well, here are our traditional risk factors, and you understand now that inflammation is the mechanism by which these traditional risk factors, including LDL, can instigate the disease and cause its complications. We now know that many traditional risk factors can stimulate the bone marrow. This has been shown to great advantage, for example, in the PESA study by looking at fluorodeoxyglucose uptake in the bone marrow in individuals, and this is a primary prevention study, who have traditional cardiovascular risk factors. And in the experimental lab, largely work of my colleagues and former students, Phil Swirsky and Matthias Narendorf, we see that a number of atherosclerotic risk factors can cause increased hematopoiesis experimentally in mice. Well, what are the messengers that mediate this triggering of inflammatory mechanisms by risk factors? There are a number of them. There are cytokines, which are protein mediators of inflammation immunity, many lipid mediators, and reactive oxygen species. I'd like to focus on cytokines because they are the most malleable and approachable of the targets for therapy. Way back in 1991, my colleague Johan Hansen and I did a little catalog of certain cytokines that are produced by endothelial cells, smooth muscle cells, macrophages, and T cells. And this list, although the names may have changed, is remarkably up to date now many years later. In my laboratory, we showed that we can induce the gene expression for interleukin-1 beta when we expose endothelial cells or smooth muscle cells not shown with a pro-inflammatory stimulus, lipopolysaccharide, gram-negative endotoxin. We soon thereafter found that we can induce interleukin-1 beta expression by exposing cells, endothelial cells or smooth muscle cells not shown, to either IL-1 alpha or beta not shown. We then found that interleukin-1, either species, can cause a remarkable increase in interleukin-6. This is a logarithmic plot that shows how a little bit of interleukin can get you huge amounts of interleukin-6. So IL-1 alpha can induce this cytokine IL-6, and I'll tell you in a moment why we were interested in that even in the 1980s. We then found that the enzyme that can convert the inactive pro form of IL-1 beta to the active mature form, caspase-1, which is the machine enzyme of the pro-inflammatory inflammasome, is expressed in human foam cells. And in the biochemistry laboratory, we found that pro-inflammatory stimuli can induce the processing of the inactive, higher molecular weight species, pro-IL-1 beta, to the mature active form shown here. So now we have a biological pathway. The inflammasome can sense danger and activate caspase-1, shown here in purple, which can induce the processing of the inactive forms of IL-1 beta and IL-18. We showed autoinduction, as shown here, which is an amplification loop. And then we found that IL-1 can induce enormous amounts of interleukin-6, which you'll hear from Dr. Ridker is causally involved in atherogenesis. Why were we interested in IL-6 back in the late 1980s? Because we already knew that it is the stimulus for what we call the acute phase response in the hepatocyte. The acute phase response is important because fibrinogen increases as part of the acute phase response, the precursor of clots, and plasminogen activator inhibitor is also increased. Plasminogen activator inhibitor is the major blocker of our own fibrinolytic clot-busting system. These are bad biomarkers for various reasons, but an excellent biomarker that allows us to look through the glass darkly at this whole pathway is C-reactive protein, about which Dr. Ridker will speak. So what is it that contributes to accumulation of leukocytes? I said it, hematopoiesis in the bone marrow. And that can come across from several ways because of inflammatory signaling in the bone marrow niche, the hematopoietic niche, or due to clonal hematopoiesis with somatic acquired mutations. We found when we take endothelial cells from bone marrow that they are overexpressing interleukin-6, and gene knockout experiments in mice showed that when we block endothelial expression of interleukin-6, we can decrease the precursors of pro-inflammatory leukocytes and see fewer pro-inflammatory leukocytes in the blood and even fewer neutrophils. So interleukin-6 is very important in the local pro-hematologic hematopoietic niche in the bone marrow. And we also recently have found that there are mutations which can occur in bone marrow stem cells which give rise to clones. We call this clonal hematopoiesis of indeterminate potential. Why do we care about this in cardiology? Because this condition yields accelerated atherosclerosis, thrombosis, heart failure, and many, many other conditions. And it is a potent and common risk factor in the elderly. As you see, the hazard ratio for cardiovascular disease is on par with hypercholesterolemia and with hypertension. This is an age-related risk factor and is caused by mutations, acquired mutations, in just a handful of known leukemia driver genes. So is this just a marker of aging or is it causal? And our mouse experiments were able to show when we engineer mice to look like patients with clonal hematopoiesis due to a particular mutation that's very common, that we accelerate atherosclerosis. We also found that the cells that bear this mutation, when exposed to a classical risk factor such as LDL, will overexpress IL-1 beta and IL-6. And the human correlation comes from interrogation of large cohorts that show that individuals with that mutation can have increased concentrations of IL-1 beta and IL-6 in their peripheral blood. And as you'll hear from Dr. Ridker, we can actually block some of the pro-inflammatory effects of IL-6 and the risk of clonal hematopoiesis in individuals who have genetic variants that cause a loss of function or impairment of function in interleukin-6. So actually both of these mechanisms can contribute to the increased leukopoiesis. So now just to shift over to Dr. Ridker's presentation, let me point out that it took me 100 milliseconds to come up with over 2 million citations to inflammation and atherosclerosis, and 80 milliseconds to come up with over 400,000 relating immunology and atherosclerosis in Google Scholar. So the question is, how do we take all of this experimental work and translate it to the humans? And that is where Dr. Ridker is going to pick up. This is a depiction of the NLRP3 inflammasome in the long axis view superimposed on an artery, illustrating a recent paper as part of the ATVB Centennial Collection that I did with Hafid Et Oufella, colleague in Paris. And as you'll hear from Dr. Ridker, there are a number of shots on goal. There's anti-cytokine therapy, there's cytokine therapy in low doses, there's depleting antibodies, there's antibodies that can neutralize oxidized LDL, and those that target the cytoskeleton, such as colchicine. So where are we? Inflammation is a common contributor to atherosclerosis and is becoming clinically actionable, as you'll hear from Dr. Ridker. And I think we're at an early stage. As Churchill said at a certain point in the Second War, this is not the end, it is not even the beginning of the end, but it is perhaps the end of the beginning. Thank you very much for your attention.
Peter, thank you so much for a terrific introduction to the real vascular biology underlying so much of the inflammation and atherosclerosis concept. I want to reiterate for people who are hearing this perhaps for the first time that we're not setting up a dichotomy here between LDL cholesterol and inflammation. The two of these are working together, as you nicely laid out, to promote atherosclerosis and early atherogenesis. Can you talk about that a bit further? Because sometimes people think that these two things are really separate processes.
Well, as I said, there's no competition whatsoever between traditional risk factors, which you and I believe in fervently, and which we treat in our clinical practices with great aggressiveness, depending on the risk. But just saying that high LDL is causal in human atherosclerosis doesn't tell us how it works. Hypertension and the neurohumoral milieu that gives rise to hypertension, how does that work? And so on and so forth. Diabetes. Is it just hyperglycemia that's driving the accelerated macro and microvascular risk in diabetes? And this is where inflammation comes in because it helps us to understand the mechanisms by which these traditional and well-established and important clinically treatable risk factors can change the behavior of the artery wall, give rise to the initiation of atherosclerosis, can promote the growth of plaques and the evolution of plaques, and ultimately can lead to the thrombotic complications, both by effects on the atheroma itself, but also, as I pointed out in my talk, on the fluid phase of blood. High fibrinogen, high inhibitor of fibrinolysis can make it so that a given plaque disruption can cause either just a mural thrombus that's subclinical or lead to an immediate occlusive thrombus that can give you a C-segment elevation myocardial infarction. So really, inflammation is the missing link between traditional risk factors and the clinical complications that concern us as practitioners.
Really at a time where we have to have our clinical colleagues recognize that both of these processes are crucial for this disease. It's no longer enough to focus only on the lipid side of this. We have to think about both. How do you think the oxidized LDL hypothesis fits here? Some people have argued that's a good way to tie these two together as an activator of both innate and acquired immunity.
Yes, so there's a huge literature about oxidized phospholipids that associate with LDL particles, for example, and risk of atherosclerosis. And this has given rise to many clinical trials, some of which were done in the unit where you work, with antioxidant vitamins, which have really flamed out in terms of reducing events one after another. And this includes lipophilic antioxidants that should partition right into the LDL particle, and soluble antioxidants such as vitamin C. And then there have been targeted antioxidant therapies that have been used, such as succinylbucol, that was targeted in a study, I believe it's called ARISE, that was a terrific molecule for inhibiting LDL oxidation, but that failed to reduce events in a large-scale, well-conducted clinical trial. So while oxidation is definitely important and oxidized LDL may be a marker of risk, it has not proven to be a viable clinical target despite decades of investigation. There is hope, however, that antibodies that attack or that recognize not oxidized phospholipids, but actually the modified apolipoprotein B, the signature apoprotein of LDL, may have anti-inflammatory mechanisms that could give benefit, and that is being studied now in a large-scale clinical trial known as FORTIFY.
here. Many people probably don't know that you run a CHIP clinic, really focusing on patients who have clonal hematopoiesis of indeterminate potential. A minute about why you do that and how it's going.
Oh, because it's fun. Think I'm seeing. I have a full day of patients on Friday, uh, but in the morning I start out with three CHIP patients, and these are fascinating individuals who have sustained these mutations in stem cells in their bone marrow, and that then show up with peripheral blood that contains a clone of progeny of those original stem cells. And it's been a wonderful journey to try and figure out what's going on here. This is an unsuspected link between cancer and cardiovascular disease. And it's hard to open up a journal nowadays without finding a relationship of some disease, cardiovascular and other diseases with CHIP. So it's a fascinating arena to be in, and particularly perilous because we don't have any evidence base. So I practice preventive cardiology raised to a power in these patients and take care of their traditional risk factors in the hope that that will prove beneficial for their outcomes and help to mute some of the elevated risk which certain of these mutations can associate with.
Introductory talk on the vascular biology of inflammation. It's greatly appreciated.
Thanks. Thanks a lot. Great to work with you as always, Paul.